Hello viewers, I am Pratik Bhatt from Bharat Serums and Vaccines, and on behalf of Bharat Serums and Vaccines, I welcome you all to the 31st episode of ART Masterclass Season 1. Couple of days back, we had Dr. Anshu Jindal talking about ovum pickup, and today we have with us talking about embryo transfer. She'll be talking to us about optimizing embryo transfers and sharing 10 secrets, her 10 personal secrets about optimizing a good embryo transfer. Talking about Dr. Anshu Jindal, she has done her MBBS, MD from New Delhi, DNB, MNM, MNAMS, FICOG, and she's been awarded a gold medal for overall best performance in MD from Delhi University in 1995. Currently, she is the clinical director and IVF specialist at Jindal Hospital, Meerut. She is the joint secretary of UT ISAR, and she is actively involved as a member of Infertility Committee of FOXI. She is running a FOXI accredited center of excellence for both laparoscopic and infertility training. She has delivered more than 11,000 children by various techniques of infertility. She has appeared on the front page of Times of India for her pioneering work on firstly delivering the second tallest woman of the world, whose child is the only surviving progeny in the world for a woman over 7 feet in 2007. Secondly, delivering twins to a male by a test tube baby, which received worldwide publicity. She is regularly invited as a faculty at both national and international conferences, and she has authored 8 chapters in textbooks of infertility. She has done pioneering work on bilateral ectopic and heterotopic cornual pregnancy. She is highly decorated by various social organizations, including Meerut Rattan in 2008, Green Earth Award, HT Woman of the Year Award. She is actively involved in imparting sex education programs in schools in and around Delhi NCR. With this, now we hand over the session to Dr. Anshu Jindal. I request my audience to use the chat box for any questions that they have for Dr. Anshu. Dr. Anshu, the session is yours.
Thank you so much. So thank you and welcome back to the second session on a very important topic in IVF, that is optimizing embryo transfer. We just talked about ovum pickup 2 days back, and today here I am back again sharing with you 10 secrets of a good embryo transfer. So we know that embryo transfer is the final and the most critical step in the success of an IVF cycle. A good embryo transfer determines the success of an IVF cycle, and it requires a perfect synchronization between the embryologist and the IVF specialist. And now, with single embryo blastocyst transfer, single embryo transfer, and evolving culture systems, the culture systems are becoming more and more defined. Time-lapse systems, the IVF is really taking strides, and we are really going deep into the IVF technology. We need to go deeper in the embryo transfer technique also. And that is why I have come up with this wonderful lecture. Live birth rates in IVF are a function of 3 things: selecting the best embryo, uterine receptivity, and the embryo transfer efficiency. So it is this topic of embryo transfer efficiency which we are going to deal with in detail today. We know that selecting the best embryo with the embryo selection criteria has now changed over the years. We used to have just morphological criteria around 2 or 3 decades back, but now with metabolomics, proteomics, genetic markers in culture media, time-lapse technology to look for the development of the embryo, blastocyst culture, single-step or sequential media, and with the advent of PGTA, on trophectoderm biopsy prior to ET, there have been such advances in the field of IVF that, even our technique of embryo transfer needs to be looked into. And now to add to it, we have the non-invasive chromosomal screening method, which is NGS based. On the blastocyst culture media, they can detect the genetic disorders in the embryo without doing a trophectoderm biopsy. So this is where IVF is leading us, and we need to talk about the embryo transfer techniques also. There are a lot of factors which affect embryo transfer success. First of all, the ease of the procedure. With what ease did you complete the procedure? Did you encounter any difficulty while you were doing an embryo transfer? On the embryo transfer catheter, the use of ultrasound guidance, the position where you have placed the embryos, the experience of the physician, the use of cervical introducer or the stillet or the obturator, as you call it. And after transfer, looking for a presence of blood or mucus on the catheter tip or on the sides of the catheter, bacterial contamination of the catheter, or even retention of embryos in the catheter. So, if any of these points are missing, or if there is a problem at any one level, then your transfer can be difficult, and your success of an IVF cycle can also get affected. What is a gentle atraumatic transfer? A painless transfer where there was no resistance at the internal os, because that is the place where you encounter the most resistance. Or you can have an S-shaped cervical canal, and that is why negotiating through these canals and negotiating the internal os actually becomes a challenge. Or transferring at the maximal implantation site, which is MIP, with no blood or mucus on the catheter tip. This is what a gentle atraumatic transfer is. And your catheter, your choice of catheter, plays a very important role in giving you a success in IVF. An ideal ET catheter is soft enough to avoid trauma to the endocervix or the endometrium, but malleable enough. It should be able to negotiate the directions of the uterine cavity along its natural contour. And firm catheters are actually very useful in patients who have difficult embryo transfer, because they can be associated with more bleeding, trauma, and even stimulation of uterine contractions. But at times, you have no choice but to use firm catheters, especially in patients with difficult transfers. So here I've shown you quite a few catheters, and the choice of catheters actually should be decided. Sometimes it can be decided earlier at the time of mock ET, or it can be decided actually at the time of the real embryo transfer. So catheters have an outer sheath, a thick hollow tube. These are for difficult transfers. The obturator which fits snugly within the outer sheath, which is actually made of metal, and it helps in negotiating the curvature of the endocervix. And we have the inner sheath, the soft tube with markings at the distal end of the tip, and it is in this inner sheath that the embryos are loaded. So these catheters really help us in difficult transfers. And now we have some echogenic catheters, because most of IVF specialists are doing the embryo transfer under ultrasound guidance. So now we have special echogenic catheter, the Show Pro Ultra from Wallace Kinetics, and even Cook's EcoTip catheter, where you can visualize the catheter all along as it traverses the uterine cavity. So two recent meta-analyses, and they compared the use of soft catheters as well as the firm catheters, and they found that the firm catheters, the rigid outer sheath of the soft catheter, can also be bent. So the main thing is to align yourself to the uterine axis. And this obturator, along with the outer sheath is placed at the level of the internal os, and the stillet is then removed, and then the inner catheter, the inner sheath with the embryo, is then placed inside. As you can see in this diagram, you can see the inner catheter, which is then, the outer sheath is placed right only till the to the internal os, and it is the inner sheath which goes inside and places the embryo almost 1.5 to 2 centimeters below the fundus, which is the place of maximal implantation point. So there are a lot of talk about loading the catheter, and there are various ways of loading the catheters. The most popular way is you take the medium, you take air, the embryo with the medium, then again an air bubble, and then again medium. So 42% of the cases, this is the most popular method of loading your embryos. Or it could be just with medium with embryo at end in 20% of the cases. or it is usually medium air embryo in 15%, medium with embryo with no air in between in 7%. And there are other factors also which actually influence the success. That is the time of loading the catheter and the real embryo transfer, that is from the incubator to the uterus. And this is the embryo is affected by the light, temperature, and the environmental factors, and it should always be less than 120 seconds. The speed with which the embryos are ejected inside the cavity, and retained embryos if found, if they have to be transferred back. So all these factors, the loading technique and all these factors, the time of loading and transfer, the speed with which the embryos are ejected and retransferring. So all these will have an influence on your success of IVF. Then after you have you have done the embryo transfer, did you withdraw the catheter, the ET catheter immediately, or was there a 30 seconds delay? And this study in human reproduction by Martinez et al. Found that there was no difference even if you withdrew the catheter immediately or if there was a 30 seconds delay. But embryo trauma can be related to the rapidity of the injection, and care should be taken to inject the fluid a little slowly, steadily. And it has also been seen that sometimes when you inject the fluid very rapidly, when you eject the embryos with the medium a little rapidly, then there is a possibility of causing ectopic pregnancies in these patients by this paper by Iritin et al. In Fertility Sterility in 2007. He says that you should be gentle when you are ejecting your, the medium with the embryos in the uterine cavity. So let's talk about mock ET. How does it help? And does it really help? Mock ET should be done. Actually, now with ultrasound guided embryo transfer, things have become more, easier for an IVF specialist. And when we started with practice, we were also doing mock ETs in all our patients. We do mock ETs still, but nowadays in COVID times, I think we are most of the time we are just doing a real embryo transfer, and only at the time of the embryo transfer do we do all the assessment at that particular time. And what are the assessments that you do? The length of the uterine cavity and cervical canal, the direction of the uterine cavity, the cervico-uterine angulation is very important, because it is in some patients that this angle can be little, very difficult to negotiate. And so you should make a note of the cervico-uterine angle. Choosing the most suitable catheter. In fact, at the time of embryo ET, mock ET, you can decide that this patient's embryo transfer is going to be difficult. And so you can choose a catheter. You can make a note in your notes that this patient has a difficult embryo transfer. And the timing of a mock ET is usually, if you're doing an agonist cycle, it is in the -1 cycle. And in an antagonist cycle, it can be done even in the beginning of your ovarian stimulation. The only disadvantage of doing a mock ET and putting your notes is that there could be a difference between your blind pre-cycle trial transfer and the real transfer. There could be some differences, because sometimes even with bladder being overfull or bladder being, not so full, it makes a difference in your calculation of the uterocervical length at which you have to do the transfer. So always, even if you have made a note of the uterocervical length in mock ET, you should measure it again at the time of embryo transfer. So ultrasound guided soft catheter embryo transfer definitely is the trendiest thing, and also the most important thing, because it improves the pregnancy rate. There has been this paper where they compared the embryo transfer against the clinical transfer without ultrasound, and what they found is that definitely ultrasound improved the clinical pregnancy rates as compared to clinical touch transfer. And when they compared hard catheters to soft catheters in this paper, they found that soft catheters were much better than hard catheters. So the conclusion of this paper was that the performance of embryo transfer with a soft catheter system under ultrasound guidance actually increased the clinical pregnancy rates. Then where do you deposit these embryos? The maximal at the point of maximal implantation point. And where is this point? If you draw two lines, two imaginary lines extending from the fallopian tubes goes inside the uterine cavity, where these two lines meet, that is the point of maximal implantation. And this is the point, usually it is 1.5 to 2 centimeters below the fundus of the uterus. And it is at this site that the embryos should be transferred for good implantation rates as well as for good pregnancy rate, and also to lower the incidence of ectopic pregnancies. Then blood or mucus on the catheter tip. It has been found that there has been a little controversy on this. Some studies have very categorically said that blood and mucus on the tip of the catheter was associated with significantly lower outcome by this paper, Infertility, Sterility by Dasage et al. In 2011. And it not only interferes with the deposition of the embryos, actually the mucus, because of its tensile strength, it can drag the embryos into the endocervix while you're withdrawing your ET catheter. So cervical mucus should definitely be removed prior to ET. And cervical mucus can also become a source of contamination, leading to some infections, endometritis, and reducing the rate of implantation from 9 to 16% by this paper by Franchin et al. In 1998. So blood or mucus on the catheter tip is not a good sign, and hence mucus removal should be done prior to you do an ET. About bed rest, should bed rest be done? Whether it should be, and for how long the patient should do bed rest, should it be an extended bed rest or virtually no bed rest? Actually, recent analysis, including a meta-analysis, have failed to demonstrate a clear improvement in ongoing pregnancy rate with bed rest. And some trials have even gone on to say that it can have actually a detrimental effect on the ET outcome. And what is recommended is that 20 minutes of rest after an embryo transfer, and then the patient can be allowed to move about. And actually, bed rest has actually no role. Now, if you were to discuss the technique of embryo transfer, you ask the patient to drink water, because we are also doing all our embryo transfers under ultrasound guidance. So at least 45 minutes before the procedure, the patient should drink enough water, should have a full bladder, and patient should be informed about the number of embryos that are available, the fertilization rates, and the number of embryos we have selected for the transfer, because I think transparency really helps. When we started with our IVF practice, where we were doing ultrasound at the time of mock ET, we always used to have an ultrasound picture in our ET room to see the uterine cavity, the direction, and everything at the time of ET. But now with ultrasound guidance, it is all live now. You can see a live picture on your ultrasound machine, and you can see the length, the direction, the cervico-uterine angulation, which is very important. The patient this is all is noted at the same time, made a note of. The patient is put in the thoughtme position, cleaned with normal saline, cervix is visualized using a Cusco speculum, and you use swabs to clean the cervical mucus, and you can even use your IUI catheter, or an ENT player's probe is also sometimes used, like we have shown here, to clean the cervical mucus, to aspirate the cervical mucus diligently from the endocervix. And then you measure when you put your probe on the patient's abdomen, you measure the length, direction, as I just said, and the cervico-uterine angle. And sometimes this angle can be very acute. It can be a small angle, as you can see here. It can be a straight cavity. And by the way, a full bladder actually helps in straightening the cervicouterine angle. And this is a very small angle, less than 30 degrees. It can be a little more, which is makes the embryo transfer difficult. It can be moderate angle of 30 to 60 degrees, or it could be a large angle of more than 60 degrees. And more the angle, the difficult your embryo transfer is going to be. So now that you are ready, your ultrasound machine, you have put the probe on the patient's abdomen, and you have aligned the uterus, you get a clear ultrasound image, and you definitely need a good assistant to do this for you. And you see the point of maximal implantation. Now with 3D and even 4D ultrasounds, you can even get even a more detailed picture, but I think 2D ultrasound is good enough for a good ET, and 3D is actually not required. So this is a video of one of our embryo transfers. You can see the beautiful straightened cervicouterine angle is very straight. You can see the endometrial cavity here, the tip of the fundus, the catheter. It's reached here. And I think I can play it again for you. See, you can see the catheter. It is negotiating it is already negotiated the internal os here. Yeah, there you are. It's reached the point of the maximal implantation. There it is, an echogenic tip. The ET catheter can be easily visualized on your ultrasound picture. And even if you don't have an eco tip, because these eco tip embryo transfer catheters are more expensive, even a normal ET catheter, which are less expensive, can serve you very well. A soft catheter is always better, and embryos should be loaded in very little amount of media, which is flanked by air bubbles on both sides. Only 30 microliter of fluid is the ideal media in which the embryos are suspended. And the embryos are then ejected as gently as possible, and the catheter is then slowly withdrawn from the uterus. Immediately it can be withdrawn, keeping the plunger stable, because you don't want to pull the plunger, otherwise you're going to create negative pressure, and the embryos can come back into your catheter. And the catheter is then returned to the working table of the laminar flow and inspected by the embryologist to check for any retained embryos and document the presence of any blood, mucus, or any endometrial tissue, either on the tip or even on the sides of the catheter. And most important is that it should not be on the tip, preferably not on the tip. Sometimes when it is negotiating the endocervix, it can be on the sides. So we will discuss how it actually affects the results. So embryo transfer in the afterloading technique, it's a refinement in embryo transfer technique, and it is done in difficult cases. Again, under ultrasound, it consists of the embryo transfer catheter consists of the three things that I talked about: the outer sheath, the obturator, and the inner sheath. And what is generally done is that the outer sheath is placed at or just beyond the internal os. The obturator is then removed from the outer sheath, and the inner sheath of the soft tip catheter is then loaded with the embryo, is passed by the embryologist to the in IVF specialist, and this inner sheath containing the embryos is then threaded through the outer sheath, and goes beyond the inner sheath with the embryos, is then slowly advanced to the point of maximal implantation point, and the embryos are placed there. And this afterloading technique not only makes difficult embryo transfers difficult, it decreases the time in Jindal and decreases the usual contamination of the ET catheter with mucus or blood. So hence, it's a very good technique to be used in patients who have, if they have infections, or if it is a difficult transfer where it is difficult to negotiate your way through the internal os. So the afterloading technique is preferred by a lot of IVF specialists all over the world. Then there was a lot of talk about the air bubble position, that after the transfer has been done, what happens to the air bubble, which actually does the embryo stay where you place it, or does it move up and down with movement? So what the review of literature found, that on standing after an embryo transfer, 94% of the air bubbles show no movement, and 80% of the gestational sacs are found in location where the air bubble was seen at the time of embryo transfer, which means if the air bubble doesn't move, then it is a good prognosis, and your chances of the patient getting pregnant, because you're transferring it at the time, at the point of maximal implantation, and hence your chances of pregnancy are more. But if the air bubble move, which can happen in 6 to 10% of the cases, the air bubble can move, pregnancies can still happen, but definitely there could be a decrease in pregnancy rates. Then the catheter after the embryo transfer is checked for any retained embryos, and if found, then what has been suggested is that retransfer can be done immediately without causing any detrimental effects on the clinical pregnancy rates. Bed rest for 20 to 30 minutes, and bed rest for more than that is usually not necessary. And as I just said, that if they are retained embryos, they can be transferred immediately. There has been a lot of talk about hysteroscopy, whether hysteroscopy would help you in your embryo transfer and would refine your embryo transfer, and should it be a part of pre-IVF evaluation. So we have already, this is not a podium to talk about hysteroscopy for all or not, but definitely I would just like to say that pre-IVF evaluation by hysteroscopy is a must if the patient has any cavitary problems, like if there are any problems with the cavity, like submucous fibroids, polyps, adhesions, they should be taken care of. And especially in patients with stenosed cervix, it corrects the problem and it makes your embryo transfer more easy. And hence, if you find that there is any problem, or if the patient suggests history, that like in our belt, patients do come up with history of dye interference, though it can be, maybe it is not seen all over the world. It is a problem which is very peculiar to India, where the dyes, they insert some kind of a chemicals at the internal os, at the external os, sorry, which traverses the cervix and causes stenosis of the cervix. So if you encounter any such problems, or on your pelvic checkup you find that the cervix is very stenosed, then hysteroscopy should be done to to correct this problem. And in our area, which is very endemic for tuberculosis, an endometrial biopsy for tuberculosis is usually done to rule out tuberculosis, because that also leads to stenosis of the cervix. What about the experience of the provider? I did a lot of review of literature on this and found that actually the skill of the operator also influences the clinical outcome. And when they did a study, and they found that there were differences in clinical pregnancy rate between different providers using the same embryo loading or the embryo transfer techniques. So in the hands of experienced skilled operator, the choice of catheter, difficulty in catheter in transfer, blood or mucus in catheters tip have caused a difference in clinical pregnancy rate. This is quite surprising, but this is the way it is. And so definitely the skill of the provider, how you can positively influence a patient. I know of some of the IVF specialists who tell me that they keep talking to the patient when they're doing the embryo transfer, so that the patient is relaxed. And once the patient is relaxed, then you can do a better job. So definitely here comes the skill of the provider. So, if we were to say that how do you prevent uterine contractions at the time of transfer? This is a very important question when it comes to embryo transfer, and you can do it by using soft catheters, by making your transfer as atraumatic atraumatic as possible. You should not touch the fundus, preferably not use a tenaculum because that induces uterine contractions. And in some patients, you can use prostaglandin synthetase inhibitors. Etossiban is oxytocin inhibitor, which can also be used in patients where you find that the contractility is more, or you are very tense patients. You can use etossiban. Even progestogen has a uterine relaxant effect, and that can also help. And I think tender loving care also comes here, that reassuring the patient would go a long way in performing a good embryo transfer. And as we just said, it is the provider also who makes a difference. Embryo glue, which is implantation promoting glue. It's hyaluron enriched embryo transfer media. And there has been a lot of talk about it. And it's supposed to aid in implantation, improve the pregnancy rates, decrease ectopic pregnancy rates, lower the miscarriage rate. But more RCTs are required before we can really promote and say that it has a real definitive results. Transmyometrial embryo transfer is another thing which is done only in patients who have very stenosed cervix. I personally do not have any personal experience with it because it is a tricky thing, because the Toyako technique is there, which they do a transmyometrial embryo transfer, but there is more risk of junctional zone contractions, resulting in a decrease in success rate and leading to expulsion of embryo from the uterine cavity. And even holding the cervix with the tenaculum actually can also stimulate the TZ contractions, the transformation zone contractions. So this is another field altogether. I have never used it in any embryo transfer, and so I don't know how if good it or bad it is. So I would the American Society for Reproduction has given some guidelines for performing the perfect embryo transfer, and they recommend the grade A or good evidence is 10 RCTs recommend ultrasound guidance is clearly the way forward for a good embryo transfer to improve the clinical pregnancy rate and live birth rates. Use of soft embryo catheters to improve the IVF results. And the data on live birth rate and specific types of embryo catheters are limited, but there are so many companies which are coming up with very good soft catheters that should be preferred, and not to recommend any bed rest after embryo transfer. This is good evidence, grade A evidence. The fair evidence is that acupuncture performed around the time of embryo transfer does not improve the live birth rate in IVF. And there is a fair evidence based only one RCT that transcutaneous electrical acupoint stimulation, TES, improves IVF embryo transfer outcomes. Given the lack of any other studies, recommendation for or against TES to improve IVF embryo transfer outcomes cannot be made. Fair evidence based on a single RCT that an antibiotic regime that includes amoxi and clavulanic acid given on the day before and on the day of embryo transfer actually does not improve pregnancy rates. And a benefit of removing the cervical mucus at the time of embryo transfer to improve clinical pregnancy rates are it is recommended. It is fair evidence that it should be done. 7 studies, 3 RCTs and 4 cohort studies, that the placement of the catheter tip in the upper or middle, that is the central area, the center of the leaf, or as we call it, 1.5 to 2 centimeters below the fundus, is very good in order to decrease embryo expulsion and optimize pregnancy rate. One RCT and one cohort study recommends immediate withdrawal of the embryo transfer catheter after embryo expulsion and not wait for 30 seconds. And retained embryos in the transfer catheter can be immediately retransferred, do not affect the implantation, the clinical pregnancy rates, or the abortion rates. And the grade C evidence is insufficient evidence to recommend. There's insufficient evidence to recommend for or against analgesics, and routine anesthesia is not recommended to improve the ET pregnancy rates. And routine anesthesia is only used in patients in whom you are anticipating difficulty and you have done a mock transfer and you find there is difficulty. And I think in these patients, it is very good to do a hysteroscopy to plan this out and to smoothen out this problem beforehand only. Insufficient evidence for more specific recommendations regarding the positioning of the catheter, but at the time of embryo transfer. Insufficient evidence to conclusively state that the presence of blood on the catheter once it is withdrawn is associated with lower implantation of pregnancy rates. Even I have seen it in my practice that many a time there could be even blood on the tip of the catheter, but the patient gets pregnant. So there is not actually, it's grade C evidence whether blood on catheter tip actually is, decreases the pregnancy rates. And insufficient evidence to recommend any specific injection speed of the catheter at the time of embryo transfer. So with these, I come to the end of this presentation, and we will have a question answer session soon.
Thank you so much, ma'am. We'll now start with the question answer session. So the first question is, hello?
Yeah, I'm there. Yeah, I'm very much audible.
Okay. So I'll take the first question. Can serum progesterone levels on day of trigger give idea regarding implantation rate in fresh transfer? Or is high progesterone on trigger day clinically correlated with lower implantation?
Yes, it has been found by many studies that the serum progesterone more than 1.5 nanogram per ml on the day of trigger can have a detrimental effect on the pregnancy rates. And it is in these circumstances that you should do a freeze all and transfer the embryos in the next FET cycle. This has been proven by RCTs. It does have a bearing. But there is a controversy between 1 and 1.5. So progesterone rate more than 1.5 are significant. Yes.
Okay,
you should not do a fresh embryo transfer in such cases.
Second question, ma'am. Is there any role of injection HCG for preparing endometrium for embryo transfer in patients with low FSH and LH?
For giving HCG before embryo transfer, or
yes.
what?
Any role of injection HCG for preparing endometrium in patients with low FSH and LH?
Low FSH and LH, I know there's no role of an HCG. There is a role of giving an intrauterine HCG prior to embryo transfer. There have been some studies which have said that you can inject HCG intrauterine to improve your embryo transfer rates, to improve your pregnancy rates in ET. But there is no role of of HCG in preparing the endometrium with low FSH and LH. No, there is none.
So there is a day 3 frozen embryo. Can we thaw and transfer on the same day, or should we thaw overnight and transfer at morula?
If it is a day 3 embryo, it has to be thawed and it has to be transferred the very same day. You cannot, this is a question which actually will be answered better by an embryologist. But from my knowledge, if it's a day 3 embryo, it has to be thawed and it has to be transferred the very same day. You cannot go on to make it a day 5 and then transfer it on day 5, because the media requirement is different, and I don't think so that is a very good idea. It is not recommended.
Madam, Dr. Sushil Shinde is asking, with sequential transfer, does it give better pregnancy rate?
See, there are a lot of centers who are doing sequential transfer and who vouch for it, that it gives a better pregnancy rates, or that is, which means that you do a day 3 transfer and you wait for a blastocyst to form and you do a blastocyst transfer as well. So in some centers, yes, definitely they are doing transfers. I know Dr. Rishikesh Pai also is a vouches for sequential transfer, but I personally feel that either you should do. I do not do sequential transfer. So my opinion is either do a day 3 or a day 5 or a blastocyst transfer, and sequential transfer, I don't believe in it.
Okay, ma'am. So a lot of questions on, in case of retroverted, retroflexed uterus, how do you
Yeah.
proceed?
See, retroverted, retroflexed uterus, with, first of all, you have to make the patient full bladder, because that will also straighten the uterocervical, and the axis will be, the uterocervical axis will be straightened with a full bladder. And usually in difficult transfers like this, and these are difficult transfers when the uterus is retroverted and retroflexed, you can hold the cervix lip. You can either hold the usually you hold the anterior lip. So with the tenaculum you can hold this cervical lip, and that straightens the uterocervical angle, and your embryo transfer can be made easy. Then ultrasound can really help you how you have to guide your catheter. And these catheters with obturate and stillet, they really help you in negotiating very difficult transfers. So I think all these steps can make even a difficult embryo transfer easy. So you can negotiate it in this way.
Uh, One of the most frequent question is, ma'am, which catheter do you prefer for embryo transfer?
Yeah, we use the Wallace catheter. We are doing that with, I'm doing both after loading technique, as well as I'm doing direct transfers. In easy transfers, the direct transfers with we are either using Wallace technique or even the Cook's catheter I use. So it's there. It just depends on what you're more comfortable with, what you have been doing. And these catheters with stillet and with an obturator, these are very good for difficult embryo transfer. We use it. We even use the CCT's catheters for that.
Debate of the millennium: single embryo transfer is better or double embryo transfer?
I know we are moving towards single embryo transfer. We are moving towards single blastocyst transfer. So definitely single is better than double, because one should avoid multiple pregnancies at all cost. But in older women, in women more than 35 years, or when you know that your embryo quality is also not very good, then I think even a double transfer is not a bad idea to go ahead with a double embryo transfer. So you have to see how the situation is. You have to individualize every case. There's no one rule for everybody. One thing doesn't fit all.
Fantastic, ma'am. With this, we'll take the last question. How much do you recommend to do a laser hatching? Is it good to do on day 3 embryos or blasts if done to increase pregnancy rate?
Laser hatching is not recommended anymore. It is not recommended. When it started around a decade back, it had become very popular. But now laser hatching is not really is not recommended anymore. Now the trend is to do a blastocyst transfer, and usually you can achieve that without a laser hatching. So
So, one last question, ma'am, which is very repeated. That is
yeah,
management of thin endometrium, madam. How do you go ahead with management of thin endometrium?
thin endometrium.
Thin endometrium,
Did
management
I
of
hear?
thin endometrium.
Yeah, management of thin endometrium is another full lecture because there are so many factors which are responsible for thin endometrium. First, you have to know the cause of thin endometrium. In the areas in UP where I come from, tuberculosis is one very important reason for thin endometrium. Endometritis is very common. Repeated abortions, repeated DNCs, and dye interference. These are very important reasons for thin endometrium in our belt. So that in these cases, it is a hysteroscopy actually, which will do will really straighten the problem for you, which can really tell you what exactly is going wrong. If the patient is tubercular, she needs anti-tubercular treatment for at least 6 months. If they are synecdoche, you need to remove the synecdoche. And always after clearing all this, if there's a polyp, you need to do a polypectomy. If there's a submucous fibroid, everything needs to be cleared. And after that, always in the -1 cycle, I always give them estrogens to see how the endometrium is building up. I don't take these patients for IVF till I'm convinced that her endometrium is going to behave well during an IVF cycle. So you can build it up by giving her proginova or estrogens, Valerate, for from the fifth day of the cycle in the dose of 2 milligram to 1 TDS or 2 PD. You give it and see how it is building. Now I'm using a lot of estrogel as well because it gives us good results to see how the endometrium is building up. And if I don't get a good endometrium, I do add low dose aspirin, sildenafil. I do use even nitric oxide, don't like G-argin and all these Argitas sachet to build up the endometrium. But in my experience, what I have seen is that these things like sildenafil and G-argin sachet, they will improve on the surface of it, on color Doppler, you will see the endometrium blood fly is improved, but actually it doesn't translate into a clinical pregnancy rate. So you have to go to the root of the problem. You have to solve the problem, and you have to solve this problem prior to taking them for IVF. This problem should be sorted out before she is taken up for IVF. Otherwise, you are going to land up with a failed cycle. And sometimes I have seen that during an IVF cycle, if you get a poor endometrium, it could be a very hyper estrogenic state. The patient could be hyperstimulated. They are in a hyperestrogenic state, and then it is better not to transfer, to freeze all and transfer in a FET cycle. Build up the endometrium in an FET cycle and then transfer. So this is how I manage, thin endometriums in clinical practice.
Thank you so much, ma'am, for answering the queries. We would now request you to please sum up your session in key 3 to 4 takeaways for our audience so that they remember in their practice on day-to-day basis.
Video. Yeah. Yeah, I have. In fact, I would like to share one of my videos which I have made for my patients. So, if time permits, I can play that video. And my
Please go
take-home
ahead, ma'am.
message
Please go ahead. Please go ahead.
that yeah, 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 we can play that. But I'll just give my take-home messages. The take-home message is that embryo transfer is a very critical step in IVF, and the success of an IVF actually is dependent on a good embryo transfer. So you have to really give it the best shot. Ultrasound guided embryo transfer has really simplified, has improved the clinical pregnancy rate, and has made the life of an IVF specialist so much easier, because we used to have such difficult embryo transfers. Now with ultrasound guidance, with full bladder, it has become much easier. And soft catheter, never compromise on the catheter. Have a very good catheter. Soft catheters are better, but if it is a difficult transfers, you can go ahead and do it with the firm catheters also. They also work very well. Affect the embryo transfer results. So these are my takeaway points, and this skill is operator dependent. I remember when I started doing embryo transfers, my mentor who was teaching me, she said that doing an embryo transfer is like placing flowers on the feet of the god. When you do it so gently and carefully, this is the intention with which you should do an embryo transfer. So thing had really stayed with me, and I always think of God when I'm doing my embryo transfers, because I know that actually it is a divine power, and it has been proved by studies as well that actually it is operator dependent, that who the person doing the embryo transfer makes a difference. So this is my takeaway points for today's lectures.
Very well explained, ma'am. Very well explained. I think this will also stay with me, that this is so delicate part, and you have to ensure that you bring the best. You are creating a new baby. You have to bring your best. You have to be delicate. The warmth of a mother should come out at that point of time. I think this is very critical. A fantastic embryo transfer. Thank you so much, ma'am, for very diligently preparing the slide deck as usual. And exactly at 48 hours, we have done our embryo transfer when we started our home pickup the other day. So I didn't wanted to make this joke, but I couldn't resist any which ways. Thank you so much, ma'am.
I like the joke. I'll just play that if you permit us.
Sure. Absolutely, ma'am.
Yeah. Absolutely, ma'am. Thank you so much.
नमस्कार, मैं डॉक्टर अंशु जिंदल जिंदल हॉस्पिटल मेरठ से बोल रही हूँ। मैं एक IVF स्पेशलिस्ट और एक ऑब्स्टेट्रिशियन हूँ। नमस्कार, मैं डॉक्टर अंशु जिंदल जिंदल हॉस्पिटल मेरठ से बोल रही हूँ। मैं एक IVF स्पेशलिस्ट और एक ऑब्स्टेट्रिशियन हूँ। आज मैं आपको एक बहुत ही महत्वपूर्ण विधि के बारे में बताने जा रही हूँ, जो है अल्ट्रासाउंड गाइडेड एम्ब्रियो ट्रांसफ़र। एम्ब्रियो ट्रांसफ़र IVF की एक बहुत ही क्रिटिकल स्टेप और एक बहुत ही महत्वपूर्ण हिस्सा है। यानी कि जब भ्रूण लैब में तैयार हो जाते हैं तो उन्हें सही ढंग से बच्चेदानी में प्रत्यारोपित करना। ये बहुत ही क्रिटिकल स्टेप इसलिए माना जाता है क्योंकि आपकी प्रेगनेंसी की दर इस पर निर्भर करती है, और जितनी आसानी से यह स्टेप किया जा सके उतना ही IVF के रिजल्ट्स अच्छे आते हैं। अब आप ये जानना चाहेंगे कि यह स्टेप अल्ट्रासाउंड गाइडेंस में क्यों किया जाता है, इसके क्या फायदे हैं? इसके बहुत सारे फायदे हैं, क्योंकि अल्ट्रासाउंड गाइडेड एम्ब्रियो ट्रांसफर में हमें ये पता लगता है कि हमें तैयार किए गए भ्रूण कहाँ पर रखने हैं, कितने डिस्टेंस पर रखने हैं, जहाँ पर उनके बढ़ने की संभावना को बढ़ाया जा सके। अल्ट्रासाउंड गाइडेंस से डिफिकल्ट एम्ब्रियो ट्रांसफर भी इजी हो जाते हैं, क्योंकि हम अल्ट्रासाउंड में देखते हुए अपने कैथेटर को नेगोशिएट कर सकते हैं, उसके एंगल को चेंज कर सकते हैं। एस शेप्ड होती है सर्वाइकल कैनाल, तो उसको हम ठीक प्रकार से नेगोशिएट करके एक डिफिकल्ट एम्ब्रियो ट्रांसफर को भी इजी कर सकते हैं। इस तरीके से हम प्रेगनेंसी की दर को बढ़ा सकते हैं। आपको इससे पहले पेशाब रोकना ज़रूरी होता है, क्योंकि अल्ट्रासाउंड ट्रांस एब्डोमिनल यानी कि पेट से किया जाता है। आप एम्ब्रियो ट्रांसफर के बाद पेशाब कर सकती हैं। तो एक बहुत ही महत्वपूर्ण स्टेप है, और आपको कौन सा कैथेटर इस्तेमाल किया जाएगा, ये मॉक ट्रांसफ़र यानी कि IVF शुरू होने से पहले हम पहले से ही निर्धारित कर लेते हैं कि आपका एम्ब्रियो ट्रांसफ़र इजी होगा या डिफ़िकल्ट होगा, और उसी टाइम नॉर्मली कैथेटर का चयन भी कर लिया जाता है, और उसको नोट कर लिया जाता है कि आपका एम्ब्रियो ट्रांसफ़र डिफ़िकल्ट है या नहीं। इस महत्वपूर्ण स्टेप के लिए अल्ट्रासाउंड गाइडेंस बहुत ही ज़रूरी है। इसके अतिरिक्त आपके कितने एम्ब्रियोज रखे जाएंगे, यह भी आपकी एज पे, आपकी एम्ब्रियोज की क्वालिटी पे और आपका पहले कितने आईवीएफ साइकिल फेल हो चुके हैं उस पर निर्भर किया जाता है। नॉर्मली एक से यंग पेशेंट्स में जो 35 साल से कम उम्र के हैं उनमें 1 या 2 एम्ब्रियो ट्रांसफ़र किए जाते हैं और 35 साल की उम्र के बाद पेशेंट से डिस्कस करके 2 या मैक्सिमम 3 एम्ब्रियोज भी ट्रांसफ़र किए जा सकते हैं। सो आई होप आपको ये वीडियो अच्छा लगा होगा। थैंक यू सो मच।
Thank you so much, ma'am, for sharing the video. On behalf of Bharat Serums and Vaccines, I sincerely express my gratitude for taking time and delivering this session for us. And I thank my audience for a very patient listening. With this, we now come to an end of Masterclass episode 31 with Dr. Jindal. Thank you so much.
Thank you so much.